Okay, sir. So this is a case of a 34-year-old gentleman with a KPS of 100. He presented with complaint of headache, right ear tinnitus for 2 months. Next. His pre-op MRI brain with contrast was done. May I please request the radiologist to comment on the MRI?
Ji, Assalamu alaikum. This is Dr. Shumaila. Just a second, let me open the case at my end as well so that I can.
Sure.
So we have T1 weighted axial images in the first slide which you are sharing. I can appreciate that there is an intraaxial focal T1 hypointense area in the right parietal lobe, which is showing minimal patchy post-contrast enhancement. Go to the next slides, which is showing post-contrast images. So it is showing patchy post-contrast enhancement, which you can appreciate in the first and second image in the second row. Go to the next slide. There is only one lesion and it is T2 hyperintense. There are some T2 hypointensities in the middle of the lesion, probably the solid components which were showing enhancement in the, especially in the first and second image in the second row. If you go to the next slide, which shows T1 sagittal post-contrast images, I can appreciate the same findings. It is showing extension in the temporal lobe as well. In the next slide on FLAIR coronal images, it is hyperintense on FLAIR images. So this appears to be a neoplastic lesion. It is causing minimal effacement of the ipsilateral temporal horn, as seen in the second and third image in second row. Other than this, there is no lesion seen. There is no significant subfalcine or descending tentorial herniation. So this appears to be a primary neoplastic lesion of brain. There is only one focus, and that's it. I will consider an astrocytoma, and I will, we can further confirm it with molecular imaging.
Okay, thank you, Dr. Shumaila. This patient underwent neuronavigation guided right frontoparietal awake craniotomy, followed by the maximal safe resection of the lesion in November 25. Next, please. His post-op MRI brain with contrast was done following surgery.
So in the post-contrast images on T1 weighted axial images, there are there are post-surgical changes seen in the form of right-sided craniotomy defect. Then there are few T1 weighted hyperintensities on plain T1 weighted axial images, which are suggestive of post-operative hemorrhage and post-operative changes. In the surgical bed, there is still some T1 weighted hyperintense area seen in the region of primary tumor. If you go to the next slide, although we don't have T1 axial plane and post-contrast side by side, but there is minimal enhancement that can be post-operative hemorrhage and granulation tissue, which is showing enhancement. If we go to T2 weighted axial images, which is the next slide, we can appreciate that there is resection of primary lesion and there is probably some residual lesion seen in the surgical bed, especially along the posterior aspect of the lesion. And again, this patchy enhancement is seen on T1 weighted sagittal images in the next slide. And there is interval reduction in the size of lesion on FLAIR coronal images. So there is definite interval reduction in the size, but I can appreciate some residual lesion in the surgical bed. No new lesion is identified, and there's no collection or something else related to surgery.
The histopath of this lesion turned out to be an astrocytoma CNS-WHO grade 4 IDH mutant, and OLIC2 positive and 1p19q co-deletion was not detected.
All right. So I think now I would ask Dr. Adnan, Dr. Asim sir, oncology opinion?
So yeah, this is high grade. There is some residual. He'll definitely need adjuvant treatment. Dr. Asim is also going to see him for radiation along with temozolomide, and then we'll follow it up as adjuvant monthly temozolomide.
Right, I think.
Yeah, so I totally agree with Dr. Dan has said because considering the radiological finding and histopathological finding, astrocytoma, CNSW grade 4, though it is IDH mutant, because initially when the report histopathology was reported, it was mentioned as a high grade glioma. They recommended to get 1p19 molecular proteation status get checked so that they have an idea about whether it is a oligo grade 3 versus astrocytoma CNSW2 grade 4. Unfortunately, the 1p19q co-deletion turned out to be non-detected, non-correlated. So it is astrocytoma CNSW grade 4. So though the radiological findings suggestive of some residual disease, but still even it is a gross total recession, this patient require actually adjuvant radiation therapy along with the TMC. Thank you.
Right. Thank you. So for this sake of our own education और हमारे जो panelists हैं यहाँ पे और बाकी जो participants हैं, Dr. Adnan, when you go to Avastin in these cases?
So there were initial studies where we used to look at, especially in high grade glioblastoma, there were patients we would look for MGMT, which is an enzyme which, when methylated, does not express an enzyme that breaks down temozolomide. And in those cases, it was seen that temozolomide, does with methylation, it works well. With unmethylation, it doesn't work well. Those were the cases in which Avastin was used in frontline, thinking that because temozolomide is not going to work, you can use Avastin first line. But it didn't showed us that much of a difference. So still, in either scenario, high-grade gliomas, temozolomide along with concurrent chemotherapy is your first line. Avastin only comes as second line, where it is given in patients who has progressed on temozolomide. So that is where it would come. Now, if it is all your oligos, we know that data shows that PCV works well. So some people give PCV upfront, and then this can be followed by temozolomide. So Avastin can come third line in those scenarios. But typically, Avastin, yani bevacizumab, is used as second line post progression or recurrent disease.
All right. Perfect. Thank you.
One
Yes.
Sorry, one more indication of giving Avastin is radiation necrosis. Sometimes we do see radiation necrosis, and there also bevacizumab works because it is an anti-angiogenic. So those would be the three indications.
Right.
So, Dr. Asad, I have a
Yeah.
question regarding the recession. Considering what are the challenges, because this is a lesion that is hyperintons on flare signals, but with a little very little enhancement if we consider. So because there is some component left behind, so in this type of situation where the diffuse there is a normally the hyperintense signals where apart from the very little contrast enhancement. So during the operation, what are the challenges and how would we actually did you find any differentiation between the high grade versus this type of tumor that molecularly high grade, but not radiologically seems to be on the lower side.
Right. So,
Because you have also have a publication as well on this thing as well.
sorry. सर मैं आखिरी बात नहीं मैं समझा. अच्छा.
So you also did have a publication. You also have had a publication, na? उसमें well circumscribed
Yeah.
glioma.
Yes.
Yeah.
So मैं दो चीजें सर. एक तो if it's for example we are concerned about के location क्या है, but if it's we are not very much worried about. वैसे तो now the concept has changed. Whole brain is eloquent, right? So that's why we try to do for the intraaxial awake as much as possible. so that we have real time उनकी सारी हम वो check कर सकते हैं कि if we are causing any deficits or not. In these cases, for example, it's getting to the insula, वहाँ पे Sylvian fissure, if we are getting any major vessels there, MCA branches and all these things, so maybe surgeon might think, okay, I have to stop here. The other thing is, if it's first focus comes to the contrast enhancement part. So we attack first the contrast enhancing part of the tumor, and then flare also. So sometimes the most common challenges that we face, number one is, again, if it's a left-sided, we are thinking about language, and if the patient is not awake, we become a little bit more conservative. And then the other thing that you were mentioning, circumscribed versus infiltrating, of course, that makes a huge difference. If it's a very well circumscribed and we can just take it out, and then it's kind of the resection is comparatively straightforward. But if it's infiltrating on the imaging also, so then of course then there is a small chance. अच्छा, अगर आपने infiltrating निकाल भी दिए, जो हमारी स्टडी थी उसमें हमने देखा है कि जो आउटकम थे वो थोड़े से डिफरेंट थे in terms of operative timing also and little bit survival as well. So yes, so infiltrating versus circumscribed lesion on radiology does make some difference and the post-op outcomes. We
So
have
one of
जी
yeah,
सर.
please continue.
नहीं, मैं असल में मुझे इस वक्त अपने उसमें पैनल इसमें पार्टिसिपेंट्स में डॉक्टर मुनीब भी नज़र आ रहे हैं. सो ऑन्कोलॉजी का मैं उनसे ही पूछ रहा था. आई कैन सी डॉक्टर अकील ऑल्सो हैज़ जॉइंड अस सर्जिकल. हम उनसे भी थोड़ा सा इफ दे आर here, so we can also take them on board. Dr. Munib, anything else that you would like to add?
Assalamu alaikum everyone,
Assalamu
Dr. Adnan, Dr. Asim.
Walaikum assalam.
I just have a comment from radiation oncology perspective. I would like to discuss with Dr. Asim and other for the sake of the discussion that post-operatively, definitely this patient needs adjuvant radiation therapy. I know we all know that after WHO 2021 classification, we have divided the grade 4 tumors into GBM and astrocytoma grade 4 because of the prognosis. But the management remains same. But from the radiation oncology planning perspective, Dr. Asim, what margins do you give? Because now ISRO has published about 1.5 centimeter margins of the CTV. So how much area do you include in your practice?
So if we look at the literature, we don't right now we don't have any strong evidence in terms of any differentiation from the what was previously practiced. Conventionally, it was practiced with the 2 centimeter on the resection margin or the cosmetical disease. However, the paper that was published in recently from the ISRO group, ISRO society, that have decreased the margin to the 1.5 cm. So I still use this 1.5 cm, the only because literature currently did not, though the prognostically they differentiate the GBM IDH wild type versus IDH mutant, but still, as far as contouring is concerned, I don't think so there is any demarcation between the two. Though for grade 3 tumor, IDH mutant tumor, yes, there's a guideline also published by the ISRO group as well. They have mentioned a little bit different margin, but still for high grade glioma, whether if it is a grade 4, irrespective of IDH mutant versus IDH wild, the margin remains the same.
Just like the surgery, like from radiation oncology perspective, brain is eloquent, brain is a critical organ. We have seen that post radiation, we would like to save, if indicated, like the normal brain as much as we can. So that's why I think workup is being going on to see how much margin we could reduce. But again, we have to look at the disease, just like Dr. Hassan mentioned that if it's
So if
infiltrative, edema, and sometimes we see some with enhancing component, we also see some non-enhancing component of the grade 4 tumor as well. So we have to discuss with the radiology and take all these things incorporated into our radiation therapy plan.
So if we look at the conventional data regarding the pattern of failure in high-grade glioma, all the majority of the studies are retrospective and autopsy-based studies, and all those studies have been shown that If you are majority of the recurrence, more than 70-75% occur within the 2 centimeter. If your margin increase 3 centimeter, then the chances of recurrence reduce to almost more than 90. You have covered almost 95% of the disease. But one of the studies that I read that was published in very early 1970s, in which they did a autopsy of all the patients who diagnosed with brain tumors, and in which what they did is a slices of all the brain tissue. And surprisingly, they have found different focus in different places all over the brain as well. However, over the period of time, what the practice, as the practice evolved and as the radiology improved, still despite having this microscopic on the autopsy specimen, the pattern of failure is still in the resection cavity, and the changes that has been observed in the MRI. Based on all those things, the current status is again given the margin of 1.5 to 2 cm. Though there is a continuously trials that is being in a phase 2 study or in a small trial that was also tried to particularly when you're talking about MR based clinic, in which they have tried to actually reduce. This is from the Sunnybrook group, who tried to actually reduce margin even to 1 cm or try to minimize this further. But this is in the experimental phase, so we cannot comment whether it is a current standard of care. The current standard of care is again giving a margin of at least 1.5 cm. Thank you.
Agree. Thank you.
Dr. Akil, would you like to add anything else? Any surgical perspective?
जी अस्सलाम वालेकुम नहीं I think everything has been covered. What I do realize is कि जी this is not an easy lesion to resect, considering कि it's opercular and possibly insular, and as you said rightfully कि the disease extends beyond what is contrast enhancing.
Right.
I mean, we know for a fact that the flare signal changes also harbor active disease, and there is disease even beyond that as well. So I think GBM are, by definition, are just a diffuse disease
Right.
process. So obviously, as a surgeon, you can do awake craniotomy, or you can do diffusion tensor mapping for white matter tracts. You can do, neuromonitoring, what have you, but you just want to resect as much as possible.
Right.
But obviously, with keeping in mind that you cannot give them a deficit, because if the patients get a significant neurological deficit, all the benefit that you gain from resection is lost because of that neurological deficit, right? So there are landmark papers talking about that.
Agreed. Guilty. All right. So thank you. We can go to the next case, Dr. Kainat.
Yes, sir. So this is a case of a 48-year-old gentleman, right-handed with KPS 90. He presented with history of transient numbness and weakness in the left lower limb. He had a past history of right parietal astrocytoma, WHO grade 2, back in 2015, for which he underwent radiation therapy in 2016. Next, please. So this is the first op MRI brain. May I please request the radiologist?
Yes, thank you. So there is a T2 hyperintense lesion in the right parasagittal location. It is lying partly in frontal and partly in parietal lobe. If you go to the next slide, it is hypointense on T1 weighted images. And on post-contrast images in the next slide, it does not show any significant enhancement. All we can see are few vessels which are coursing nearby. So it's not part of the lesion actually. So it appears to be a neoplastic lesion. The grade according to these images does not appear to be very high. We do not have flare images in the first pre-op image. We only have T1, T2 and post-contrast. So that's all I can comment on.
डॉक्टर शुमाइला आप म्यूट हैं, सॉरी.
Ji,
So,
which slide I should show? Abhi?
so every
आपने
slide
पहले मुझे
has a
फॉलो
label.
पहले आपने मुझे
Follow.
फर्स्ट प्री ऑफ एमआर दिखाया जिसके 3 आपने मुझे सेट ऑफ इमेजेस दिखाए T2 T1 एंड
Right.
T1 कॉन्ट्रास्ट
Hmm.
एंड देन आफ्टर दैट प्रोबब्ली आई वाज म्यूटेड जो 2022 का आपने फॉलो अप एमआर
Ji,
दिखाया
ji,
है
ji, ji, ji.
जी आई थिंक आई डिड नॉट एक्सप्लेन दैट सो there is a residual area of T2 hyperintensity which is showing peripheral flare hyperintense signals. The second row is flare images. So I can appreciate that there is some peripheral area of flare hyperintensity, although we did not have flare in the pre-op images. But then I can appreciate in the first image in the first row that there is an other area adjacent to this interiorly, which is flare hyperintense. And since I did not have flare images initially, but on T2 I could not appreciate that. Here I can appreciate that area in
So, Dr. SS, sorry, but your slide didn't match with what Dr.
आप
This
पीछे वाली
Sumara
स्लाइड पे जाइए
पीछे
जिस पे फॉलो अप एमआरआई इन 2022 लिखा हुआ है ऊपर
Ji.
जी
this
उस पे
one,
देखिए आप
yeah.
जी so there is an other area anterior to this lesion. So if you look at the T2 and flare images, the first image and first and second row, anterior to this lesion, there is an other area more evident on flare images. It was not seen on T2 weighted images in the pre-op scan, the initial pre-op scan which you shared.
Right.
So probably I think this is an other lesion which is developing, and the surgical bed shows peripheral gliosis seen as flare hyperintensity. Just a second. So now we have the second pre-op
Yes.
MRI brain. So
Yes.
so another surgery was done after that 2022 scan?
Yes, I think patient underwent another surgery this year.
Okay, so I mean after 2022 we do not have any scan, and we are, in 2025 the patient had a surgery and we just have
Pre-op.
this is a pre-op.
So,
Okay, right.
yeah. So, Dr. Sumara, the patient was on continuous follow-up. The last MRI was done in 2022. He was he didn't have any treatment. So, patient remained well clinically. In this year, 2025, the patient developed symptoms for which this MRI was done in October.
According to what I could see in the previous pre-op in 2022, I could appreciate that there was an other focus developing. So I think even at that time the lesion wasn't stable because um, the primary lesion which was operated, other than that, anterior to this there was an other lesion developing, and probably that was leading to the thought that this is becoming a multifocal glioma or an infiltrative lesion which is showing interval progression to another side, जिसमें से हम कुछ some of it was visible radiologically. So if you come to this follow up, इसमें तो आपको you can appreciate that we already discussed in 2022. So we will go to the next follow up, which is after 3 years. Right, there's an interval of 3 years in this, and I can appreciate that then that area which was slightly visible on the previous images has become more clearly visible. It shows vasogenic edema, finger-like vasogenic edema in the same site where I could see an initial lesion in 2022. And the surgical bed and resection cavity appears, wider on T2 weighted images. So you have gone to the flare images.
I
अब
think
बहुत आगे चलेंगे,
मैं
ज्यादा मेरे से ज्यादा तेज जा रहे हैं आप.
I think because I think I just want to keep what you are saying, but I think हमारा वो different computer maybe.
अच्छा, okay.
Yeah. Yes, ma'am.
ठीक है.
So
नहीं,
I'm
I was
on
just
T2
looking
now.
at the clock. I thought you are running out of time, लेकिन time तो भी
No,
काफी
no,
है.
no, no. I'm not running. We have all the time, ma'am.
Okay, okay.
Yes.
So on T1 plain images, after T2 go to the T1, the next slide.
Yep. Yep.
So on T1 weighted images, this area is hypo-intense to iso-intense. Go to the next slide. And on T1 contrast, now we can appreciate that there is significant post-contrast enhancement. This was not even in the primary, the initial first pre-op images. The enhancement is along the medial parasagittal location. The enhancement is very thick nodular, very solid looking, and the walls also show inner nodularity, especially in the first image on the third row image of first image. So the outer lateral wall is also showing inner nodularity. So to me, there is a great change. There is an interval progression, and the two lesions, which the other lesion and the previous surgical bed, they are kind of coalescing, becoming to appear like a solid, cystic lesion. Radiologically, there appears to be a great change. On you go to the next slide where flare images are there. Even the vasogenic edema has progressed. Further, इससे भी next पे चले जाएं. तो the vasogenic edema, which was just in the close to the surgical bed, is showing extension in the frontal lobe as well. The third and fourth image in the second row, even the last two images. So to me, there is a great change in the primary lesion. To me, the lesion started developing in 2022, and now it is showing, a very aggressive kind of increase in size. That's it from my end.
Right. Thank you.
So this patient underwent NNG-guided right parietal awake craniotomy with the resection of the lesion in November 2025. Next, please. His post-second op MRI brain was done.
I'm sorry, Kainat, what was the histology on the post-first resection?
CNS astrocytoma, grade 2.
Okay.
Okay, so this is the second post-op. Yeah. So, Dr. Shumaya,
Yes, Dr. Sir.
Ji, so on the second post-op, we can appreciate, I think these are only T1 and T1 post-contrast लिखा हुआ है, but I think these are T1 weighted images. I'm not sure about that कि ये इसमें plain कौन से contrast. The
I
first
think
row
this
is
one is
probably
the T2, and then we have. Oh, okay. So you're. अच्छा, आप इनकी
the
बात कर रहे
first
हैं. I think the first row might be plain, maybe.
plain, yes, and
Yeah.
we can see that there is some post-surgical hemorrhage which is appearing as T1 weighted hyperintensity. On post-contrast images, I can still appreciate some patchy areas of enhancement within the lesion. You can see them in the second image in the second row. There is some patchy internal enhancement. तो अगर आप ऊपर नीचे वाले compare करें plain and post contrast, we can still appreciate
Right.
some enhancement, and it is very patchy. पहले से बहुत कम है, but still there is some residual enhancement lying in the surgical bed. If we go to the next slide, which is T1 sagittal post contrast, we can again appreciate that there is some patchy post contrast enhancement, especially जो close to foxes का area है, the last image in the last row, वहाँ पे ऐसे लगता है जैसे there is some enhancement which is still lying there. On flare images in the next slide, there is some vasogenic edema which is left, लेकिन ये कि maximum interval resection तो probably maximum safe resection कर दी हुई है. कुछ जो है वो पैची enhancement के areas जो हैं, they are residual areas are lying in the surgical bed. Most of the lesion is being resected.
Right. And the histopath came.
The current histopath is the astrocytoma CNS WHO grade 4 IDH mutant with Ki67 more than 60%.
Right. और इसको पहले तो कोई वो नहीं मिली थी ना, रेडिएशन या.
पहले रेडिएशन हुई है 2016 में.
अच्छा, वो सब ठीक ठीक. Dr. Adnan, sir.
So the question, did you guys give radiation by itself or did you add something to it?
The chemo?
Yeah.
Dr. Asim, sir, इसको.
So the important thing, this patient, all his treatment outside AQH. This is the first time this patient presented to us in October 2025. So initially he was treated in 2015 with surgery followed by radiation therapy, 30 fraction of radiation therapy at that particular time, and then he remained well. But now, as he developed symptom, though he had this subsequent scan done, but as mentioned by Dr. Shumala, that was the last scan. That was in 2022. What we have right now, but clinically, patient was asymptomatic, so he just on kept on follow up. But this year, the patient developed symptom for which this investigation was done that found that is contrast enhancement and along with the progression of the disease. So this patient had surgery. Now the challenge is that because now we are talking about the recurrence in the recurrent setting along with the role of rehabilitation. Uh, I haven't actually reviewed the previous radiation detail yet, but still, because a lot of data now coming out for such a long disease-free interval of almost more than almost 10 years, one can consider radiation to that particular area, provided the family understand that the risk of radiation-induced changes or radiation-induced adverse effect might be there. Would be definitely high compared to the upward sighting, but definitely because of the long DFI, disease free interval, and the patient performances, that I think radiation can be considered in this particular patient.
So I always believe that when we approach a patient, we already know whether they will consent or not consent to any procedure. I mean, he is grade 4. He does have some signs of residual disease. He's not going to do good anyways. So sometimes you have to convince the patient in order to get the right treatment. Of course, I agree with you that there will be risk of complications compared to when you do it first time. But sometimes these patients, when you talk to them, I think we already know as physicians when we are walking into a room how the patient is going to respond and whether we'll be successful or not. So yes, I would consider radiation along with temozolomide concurrent and followed by monthly temozolomide.
Right. Dr. Munib, what are your thoughts?
Yes, I think this patient has a long disease-free interval, and I would definitely review the previous treatment plan of radiation, and I would definitely consider this patient for re-radiation. Again, we will have some discussion and thoughts about the dose and fractionation, but we could decide once we review the previous films and other parameters.
Right. Okay. Perfect. So, any other questions or comments from any participant, please? Floor is open for you. Okay. All right. Dr. Akhil, would you like to add something? I think from surgical point of view, surgery was okay. The resection was quite good.
Yeah, no, I don't have anything to add. I think Dr. Adnan and Dr. Munir has explained things pretty well.
Thank you. All right, so if we don't have any more questions or comments, this was the last case, then we can close our session. Thank you very much. Thank you all for joining us today. See you all inshallah in our next session.